Hello, Chris.
Yes. Hi, Chris.
Hello. Hello.
Can you hear well both of us?
Yes, I think so.
Good. So then I guess we will start, and I will ask Valeriya to start, and then you come for the presentation, because as far as I understand, this series we are doing with the slides and with the proper presentation, and then the question and answer session, correct?
Yes, that's right.
Okay.
Thank you very much. We are very glad to represent Professor Chris Brewin in our next meeting, in our second meeting concerning to the problems of post-traumatic disorders. And now we are going to see the report and lecture of respected Chris Brewin, and you are welcome. The floor is yours.
All right. Thank you very much, Valerie. Good. So I wanted to start by saying that traumatic events have many more impacts than simply causing post-traumatic stress disorder. But first of all, something about their nature, that we call traumatic events things that usually with little warning disrupt our everyday lives, damage our relationships and bonds with other people, and change the way in which we think about ourselves and others. And we can see the effects of these events in children, on adults, but also more widely on families, communities, and even cultures. So in children, exposure to traumatic events can be noticed because they start showing new internalizing disorders. So they might feel very anxious or very withdrawn, or alternatively, they might start acting out and being very angry and aggressive. In adults, there are many psychiatric disorders that can be produced by traumatic events. So not just PTSD, but also adjustment disorders, anxiety disorders such as phobias, depressive disorders, and also increased use of substances such as alcohol and illegal drugs. And in families, we know that they can also lead to greatly increased levels of stress and sometimes domestic violence. But traumatic events can also threaten whole communities, particularly the way that they are governed and organized, both at national and local levels, through factors such as the destruction of infrastructure, relocation of the population, the death or other removal of key individuals who make organizations function effectively, making everyday events much more difficult, such as administrative decisions or medical interventions, and limiting the resources available for overcoming problems and difficulties that would normally be fairly straightforward to solve. And it's been noticed that at a cultural level, these events can also be associated with a strengthening of social bonds, such as family ties, greater identification with the region or country, and more negative attitudes to external groups within or outside the country. And they can also lead to changes in the values that people share and in their aspirations for the future. Now, at the previous talk, I talked about these principles of immediate and midterm mass trauma intervention, and they're so important that I wanted to talk about them again very briefly. First of all, that these are the principles that can inform both what government does and what medical institutions and community organizations do, as well as families themselves. And that is to keep in your mind always that the ideal is to promote a sense of safety to calm people, to give them a sense that they can make things happen, both on an individual level and a community level, to strengthen actual connectedness or the feeling of connectedness with other people, and to give people hope. And in the ADAPT model, this is similar with slightly different emphasis, and thinks about the things that need to be repaired after mass traumatic events. So paying attention to safety and security, social bonds and social networks, but also justice, people's roles and identities, and the meaning that they find in their everyday life. Now, it's there is some recent evidence from Ukraine about the most important problems that people have described. Now, this comes from a study conducted in 2021, so before the invasion, but at a time when there was still a great deal of conflict. And the most important problems mentioned by those who'd been internally displaced were economic or financial well-being, including difficulties finding work or finding proper housing, and problems in being accepted by the local residents in areas which they have moved to. Military veterans describe problems to do with feeling misunderstood, not recognized properly, or let down by the public and government, as well as financial problems such as difficulties finding employment or accessing subsidized properties. And they also talked about a lack of understanding by their family. So I just comment that the problems described in this paper by Singh and colleagues have been replicated many times all over the world. There's nothing specific to Ukraine, but it is an important reminder that often what is most important is about practical difficulties, about how you're going to work and support your family, where you're going to live. Also, the problems described by veterans are very, very common, that after almost all conflicts, not all veterans, but a substantial proportion, talk about the difficulties in adjustment and being recognized by civil society about what it is they have been through and what their contribution has been. So while a conflict is ongoing, it's the conditions that are ideal for treating psychological disorders, such as a feeling of safety and control, will not be in place. And the international literature has much less to say about how to intervene in these situations and how effective those interventions will be. But we can imagine that they will not be quite as effective as post-conflict. But nevertheless, it's still important that in medical settings, for example, the principles of trauma-informed care, so thinking always about patients' feelings of safety, their ability to trust the people who are looking after them, and giving them as much control as is possible, are still very important, even if you can't intervene with major disorders. And it is an opportunity to improve knowledge and understanding of these disorders, so that at a future time, post-conflict, it will be easier for people to recognize what their problems are and what the solutions potentially can be to helping them to feel better. So I just wanted to say a little bit about what post-traumatic stress disorder is. And I think it's best described as a disorder which is more likely when extremely frightening or horrific experiences bring about this kind of reaction. So, for example, people might say or feel, in my mind, I gave up. They might have experiences in which their body or parts of it seem to disappear. They might notice that they felt unable to move, or it was very difficult to move. it might have been very difficult for them to think clearly and logically as they would normally do, but they just were overwhelmed by the current circumstances. Thinking you might die is also an important aspect of these experiences. And we know that during these states, when people describe these kinds of reactions, brain areas associated with planning, judgment, and autobiographical memory operate less well, and areas to do with sensations and actions operate much more effectively. Now, it's important to point out that even after very traumatic experiences, it's usually only the minority of people who develop post-traumatic stress disorder. And we can distinguish four common trajectories. First of all, the resilient trajectory, in which people never develop any or only very mild symptoms of PTSD. Then there is the chronic one, where they develop at the top of the screen, where they develop high levels of symptoms, which remain over fairly stable over a period of 1 to 2 years. A lot of people will show the recovery trajectory, in which there is an initial increase in symptoms, which then recover naturally of their own accord. So this is a group that do not generally require formal intervention with psychological treatments or drugs, but it is very helpful to them to have information and knowledge about what their reactions are and what to expect. And finally, there is a delayed group. This is usually the smallest group of the four trajectories, but it's very important because these are people whose symptoms only begin to develop later after a period of time. It may be they only develop after the conflict is over, and maybe not for months or a couple of years after the conflict is over. So it's always important to be aware of this group, who will come to the attention of doctors at a later stage, and they will have needs that need to be addressed, although they don't come forward straight away. Now, at the moment, we have two main ways of diagnosing post-traumatic stress disorder. The one that most people will be familiar with is using the American Psychiatric Association's Diagnostic and Statistical Manual. And this makes PTSD a very complex diagnosis with 20 different symptoms and a very high number of symptom combinations. And it requires evidence of exposure to actual or threatened death, serious injury, or sexual violence, and 4 different types of symptoms. So the intrusion of traumatic memories, for example, persistent avoidance, negative changes in the way people think and in their mood, and also increases in arousal and reactivity. Now, very recently, the World Health Organization has produced a separate diagnosis of PTSD, which is deliberately trying to be simpler and easier to apply in non-specialist settings. So where people don't have that many resources, there aren't many psychologists or psychiatrists, it's easier to recognize when the PTSD is being presented because the number of symptoms is smaller, but it's more specific to PTSD. And the ICD-11 requires evidence of exposure to, first of all, to extremely threatening or horrific events, and then at least one of 3 types of symptom. So first of all, re-experiencing in the present, this sense that the event is happening again now. Secondly, avoidance, that's avoiding people and places, or avoiding thoughts and memories, which are very upsetting. And thirdly, an enduring sense of threat. So people may still feel under high levels of threat, even though the actual event they know is in the past. And both these diagnostic symptoms require that the symptoms last for at least several weeks and affect the way people functioning in their work lives, their social lives, and their family lives. Now, ICD-11 has also introduced a new diagnosis of complex PTSD. And for complex PTSD, in addition to the core symptoms that we've just talked about, there have to be other impairments, such as in the way people handle their moods. So they may find it very difficult to control their moods. They may react very strongly and for long periods of time to things that upset them. They may have violent outbursts. They may tend to have dissociative states when they're under distress. They will also show persistent beliefs and changes how they feel about themselves. For example, feeling themselves to be in some way diminished, defeated, or worthless, or feeling a lot of shame or guilt. And thirdly, there will be sustained changes in how they relate to other people, and they find it difficult to relate to other people in general, although there may be some particular individuals who they're still able to feel close to. Now, the next slide shows a study from Lithuania, just illustrating the difference between PTSD and complex PTSD in ICD-11. So the line along the bottom, the green line, shows people who are resilient and have very few symptoms of either. The red line symbolizes PTSD. So you'll see high levels of symptoms of re-experiencing avoidance and threat, but relatively low levels of affect dysregulation, negative self-concept, and disturbances in relationships. While the blue line at the top shows high levels of symptoms in all those 6 different areas. And this will be the group who have complex PTSD. Now, complex PTSD has a number of other symptoms associated with it, which may make it a disturbing disorder to have. These symptoms may be quite unfamiliar, they may be very worrying, and they may worry other people, such as family members who observe them. So a common symptom is the person spacing out or becoming absorbed in a traumatic memory. It's almost as though there seems so much back there in the traumatic event that it's difficult for them to relate to where they are in the present moment. Emotional numbing is another common symptom. So difficulty in having normal emotional reactions to people and events that the person usually reports. And again, this can be quite distressing for friends and family members. An altered sense of self, such as feeling damaged or dead inside. Feeling as though others are unreal or are acting. Having thoughts about suicide, for example. And another one, which is less commonly recognized, is hearing voices. So this is similar to the voices that people diagnosed with psychotic disorders describe, even though people with complex PTSD are not psychotic, but they can still hear voices that are very direct and produce a very strong emotional effect. These voices are often very sort of critical or denigrating, and they may have a big impact on how the person with complex PTSD feels about themselves and in their ability to adapt to the symptoms that they're experiencing. The post-traumatic stress disorder affects, in particular, people's memories and the way people feel about themselves. So the effects on memory, first of all, it seems that sensations and emotions that are connected to some of these traumatic events are stored in the brain in a way that does not record time or place. And this leads to reminders of the traumatic event, leading to these events being unexpectedly re-experienced as though they were happening again in the present, either in the form of flashbacks or nightmares. And secondly, the effects on identity. The person feels unsafe and powerless. Some feel guilty and ashamed of their reactions or of surviving. Others feel alienated from others, abandoned or distrustful. And still others feel as though their future and their purpose in life has been lost. Well, I'm just going to say a little bit more about these effects on memory and identity, because they are very important and they are things that are addressed specifically within psychological therapy. So how about the impact of trauma on memory? So people have a limited set of very vivid sensory memories from the event coming to mind. So in other words, they don't tend to re-experience the whole of the traumatic event, but often it's just particular scenes or moments, a small number of those that keep coming back. But they keep coming back in an uncontrollable way, and they keep coming back in a way that is vivid and accompanied by intense emotions, and sometimes by dissociative reactions, such as spacing out or out-of-body experiences. And very simple things like being asked questioned about their experiences or being asked to recall it can produce these reactions. But at the same time, people with PTSD often report that there are gaps in their memory for important aspects of the event, things that they simply can't remember. They can find it very difficult to produce a coherent verbal description of the event. And in addition, their general memory functioning is usually worse. So they will describe, it's harder to remember everyday things, it's harder for me to concentrate. These are very, very common symptoms of PTSD. And just to illustrate the flashbacks that we've been talking about, so these are involuntary memories that are mainly based in images. So typically visual images, but they may also involve sounds, and they may also involve smells or even feelings of touch, on the feelings on the skin, for example. These are not memories that people can deliberately recall when they want to. They're memories that get triggered automatically. And when they're happening, people may actually re-experience things like the pain that was there at the time of the event, or they may re-experience heat and cold. So these are very unusual memory experiences. It's quite hard for someone without PTSD to understand what it's like to have these experiences. And I think this is one of the reasons why people with PTSD often describe difficulties in feeling understood by other people, because some of their symptoms are so unusual and things that they will not have experienced before. Another way, I think, why people think that they're often, other people don't understand what they're going through, are these changes to how they feel about themselves. So often people with PTSD will say things like, well, I'm never going to be the same person again. And they may well feel that other people are expecting them simply to recover, as though to the to kind of get back to where they were before, as though nothing had happened. They're still the same person. But for the person with PTSD, often they will feel that is not possible, that the experiences they've gone through have changed something permanently in them. Not necessarily completely in a bad way, but also, but it's given them understandings or insights or things which mean that they will always see things differently in the future. And that is very hard to communicate to another person, even someone who knows you very well, maybe particularly somebody who knows you very well. So we've talked about some of these changes in how people can feel about themselves with complex PTSD. Feelings of betrayal or abandonment are common. Feelings of being alienated from other people. But also, sometimes people describe things that they're not really having a self that they could describe any longer, a self that is in pieces, with sort of different bits that they experience at different times that no longer seem to fit together and make sense. And some people may describe almost feeling as though they don't have a self any longer because of what they've gone through. So these are really profound changes that people will never have, in general, experienced anything like this before. They're frightening experiences, and people with PTSD need sort of a lot of reassurance and time to begin within a therapeutic relationship to explore some of the changes that have taken place and to be able to put these into words and describe what life is like for them now. Now, as I mentioned before, most people do not develop PTSD following traumatic experiences, but they may develop large numbers of symptoms that then recover naturally, given time, without any therapeutic input at all. So symptoms of PTSD in themselves are normal responses to extremely frightening or horrifying events. So it's not having the symptoms that indicates PTSD is present. It's the fact that the symptoms have not gone away again and the person has not recovered. Now, we know much less about what happens to these symptoms in a situation such as war and invasion, when the conflicts are ongoing and when it's very difficult to achieve a sense of safety, when people may feel there is no safety for them at the moment. So under those circumstances, we can expect that natural recovery will be less than in a situation where there is no conflict. But there are other things as well that can act to make it more difficult to recover naturally from these experiences. First of all, the inability or unwillingness to reflect on the content of the flashbacks, or sometimes called hotspots, is a term we use to refer to the most frightening or upsetting moments of a traumatic experience. Now, often people can't reflect on these because they need to keep going. They need to continue fighting, or they need to prioritize their survival. It simply isn't possible to spend time thinking about these events. So that's a very important reason, particularly during continuing conflict, about why it may not be possible to reflect on what it is that has happened. But other reasons is that people may sometimes feel such enormous levels of anger or guilt or shame that it's just too difficult to think about these experiences. They produce such complicated feelings, such difficult feelings, that it's simply difficult to imagine talking about them or even thinking about them, so they get pushed to one side and left and not integrated into the rest of the person's history and sense of themselves. And that means that these memories can never get labeled as belonging in the past. There's always something about them that is unfinished. And under these circumstances, memories seem to retain a lot of their emotional power and can continue to trigger enormous levels of emotion and sense of threat going forward into the future. So they can continue to lead to avoidance of thoughts and memories, or avoidance of people and places, and even people throwing themselves into activities such as helping or rescuing others, which, although they're very valuable in one way, also serve the function of preventing them or making it not realistic for them to actually take time to think about their own difficult experiences, the ones that are too painful or too difficult for them to reflect on at that time. So particularly when natural recovery has not been possible, then is the situation when we turn to formal treatments for post-traumatic stress disorder. And at present, the first line treatments that are recommended are all psychological treatments. So the evidence base suggests that pharmacological interventions can be helpful in the short term to control people's mood, but they're not as effective in leading to long-term recovery as psychological interventions. So most of the time, these interventions may be relatively brief transdiagnostic treatments. So these are treatments that can be applied to a range of common disorders such as anxiety and depression, as well as PTSD. And these are included within approaches such as the Common Elements Treatment Approach or the World Health Organization MHGAP program. And these may be successful in helping PTSD symptoms with quite large numbers of people. However, they're unlikely to be effective with some people with PTSD, and particularly those with complex PTSD. And in these cases, we turn normally to specialist PTSD therapies, particularly therapies like prolonged exposure, EMDR, or cognitive processing therapy. And all of these, in their different ways, focus on overcoming avoidance of the traumatic memories. And the basic idea behind them is that by consciously attending to the memories in a controlled way, they can become less frightening and can be reflected on, evaluated, and updated. So these therapies make the assumption that the avoidance, particularly of the upsetting flashbacks and memories, is one of the key responses that is preventing recovery. And that by enabling the person systematically and carefully and in a controlled way to address those memories, they can stop becoming so frightening and stop controlling the person's behavior. So the person will never forget those events. The memories will always be there, but they will not have the same emotional impact. They will not have to be avoided any longer in the same way. They can become part of the past, like other upsetting experiences that the person has. Now, although most of the therapies that are recommended by diagnostic guidelines, by treatment guidelines for PTSD, involve some form of addressing the traumatic memories, there are other therapies that are emerging which deal more with the effects on identity. For example, the fact that people feel disconnected from others, they feel intense shame. So look at the changes in the way in which people feel about themselves. So the assumption here is that if people can feel differently about themselves, then they can spontaneously begin to address the traumatic events and memories and allow natural recovery to happen for the first time. And one particular form of therapy that's become very popular, particularly in the UK and also in the US to some degree, is called compassion-focused therapy. And this is based originally in depression, where it was noticed that people who are depressed often are extremely self-critical. They feel extremely guilty and ashamed for things that they feel they are deficiencies in themselves, or things that they've done that have been terrible. And although they can be compassionate to other people, they find it almost impossible to be compassionate towards themselves. And compassion-focused therapy is a very structured way of helping people to apply the compassionate responses that they would spontaneously give to somebody else, and to begin to apply them to themselves. See that they are really no different from another person in the same situation, that they are equally deserving of compassion, and that by beginning to respond to themselves in a compassionate way, then they can alleviate the negative way they feel about themselves, but also it can free them up to be more effective and in the world and to accomplish the goals they want to achieve. So it's not a way of being easy on yourself at all. It's a way of accepting responsibility, but also accepting the reality of what are often very difficult or impossible situations, and realizing that often people have very few choices in these situations, and that although what they did might not have been ideal, it was the only thing that they could manage to do at the time. And this seems to be very effective in changing feelings of shame and guilt, and allowing people to move forward and begin to reconnect with others and to start thinking once again about the future. Now, in complex PTSD, we've talked about the need for more structured and more complex forms of treatment. And these are some of the reasons why these kinds of treatment may be necessary, and why, even though pharmacological treatments may sort of help to control the symptoms and make them more bearable, they don't really address the central issues that are of concern to the person. So, for example, let's think about the person who's responded to these traumatic events by having a fragmented sense of self. So if they've lost that sense of a continuous self with wishes, preferences, and plans, they may not really know who they are. Who they are may change from one moment to another, from one situation to another. And this can be very, very confusing. It may be necessary to help the person explore these changes in the sense of themselves and to relate them to the experiences that they have gone through. These may be the recent traumatic experiences, but they may be also other experiences that they had in childhood that have had an influence on how they've responded to the particular trauma that they have recently been through. Traumatic events in adulthood may have reawakened earlier responses that the person had when they were a child to situations that were very overwhelming or very difficult. So exploring with people about this multiplicity or fragmentation in themselves, and treating this as a sort of normal response to a traumatic event can be extremely reassuring and can help the person to develop a proper therapeutic relationship and begin to sort of map out for themselves, well, what am I like in these situations? Who are these different what are these different parts of myself? When do I tend to respond in this way? When do I tend to respond in that way? How can I change the way I'm feeling? How can I switch or help myself to switch from one state to another? And this may be the most helpful way in which a therapist can begin to deal with a sort of very frightening internal state that feels out of control. And even just a therapist acknowledging these kinds of things, I think, can have an enormous impact on the person and allowing them to feel this is something that actually you can talk about. You can make sense of these experiences. You can share them. You can describe them to somebody else. So other complications are dissociative episodes. So temporary loss of awareness in which the person totally loses touch with where they are, who they're with, or even a fugue state in which they may, for quite long periods, act in ways like, for example, they may go on a journey to another town of which they have no memory afterwards. They don't remember making a decision to go there. They don't remember getting there or how they did or what's happened in between. So these states may put patients in danger and complicate the treatment that one can provide for a traumatic experience. So addressing issues of safety and preventing dangerous dissociative episodes from happening has to be a priority, rather than addressing that comes before addressing the traumatic experiences. So these sorts of reactions may require some previous work to help the person have a more stable sense of self, have a set of coping strategies that they can use if they feel that they're beginning to dissociate or lose control, before they begin to start talking or thinking about the traumatic experiences they've gone through. Another very important complication we've talked about a little bit before is hearing voices. And the thing about internal voices, they're often very difficult to challenge. And the person will often not have told anybody else about them. They may not feel that they can ask these voices questions. And again, beginning to discover the number of voices, what they say, what the person's relationship is with them, can make a beginning in changing what can be a very frightening internal mental state in which people can feel sort of controlled by negative voices, to begin to help them to think about the voices as mental experiences in a more objective and detached way. So you can help the person to think, well, okay, this voice is telling me something, that I've done something terrible, or I am a terrible person, or I can't trust anybody. But is this really true? You know, has this voice ever told me something that wasn't true in the past? What's the evidence for what the voice is saying? Why is the voice telling me this? Is it trying to protect me from something? And all these sorts of gentle interventions enable the person to have a more objective, detached relationship from the voice, so that although they're still present, the person isn't dominated by the voice and upset by the voice and controlled by the voice in the same way. Okay, now it's important to recognize that psychological treatment is often unwanted initially. even though they have high symptom levels. And studies that have been done on this, for example, after the Balkan War, found that the reasons included, first of all, some people had very negative attitudes towards treatment. It was seen as inefficient or inappropriate or stigmatizing. People didn't want to talk about traumatic events. They didn't trust the therapists. Other people thought that other people were more deserving and that their problems weren't so important. And in other cases, there were more practical barriers to getting access to treatment or being able to pay for it. So recognizing this kind of initial unwillingness to go to treatment is very important, and why it's necessary often to keep offering treatment in different ways, to offer different sorts of treatment through different routes, and to keep on doing it into the future so that people can in time change their mind and take up an offer that they may not have been ready to do to start with. So as we've indicated before, a lot of symptoms seem to be strongly related to the impact of loss of personal and social resources. So even though the symptoms may be about the traumatic event, it's the loss of resources that help to mean that the person does not recover naturally from these symptoms, why they continue to be a problem. Because people who are worrying about where they're going to live, how they're going to support their families, takes up a huge amount of mental capacity that they need to restore and rebuild their own lives. So financial and social support and trying to prevent subsequent stressful events from happening to people has a major impact on the course of disorders, quite independent of providing any formal treatment. And as I mentioned the other week, after the Croatian War, accommodation support was the main significant predictor of whether or not people recovered from PTSD. So that these practical interventions, the importance of them cannot be stressed highly enough, particularly for psychological disorders, not just for the kinds of reaction the kinds of response that one would want to do anyway for a population. So it's going to be good not just for economic reasons, but very much for psychological reasons too. And there are a number of different things that people can do. First of all, what can wider society do to restore mental health? First of all, the presence of signs and symbols that citizens and veterans are valued and that their sacrifice and suffering are acknowledged. Secondly, establishing a framework of fairness and justice. Rebuilding the infrastructure, but with citizens' interests being seen as having a very important role. So after the Second World War in the United Kingdom, we had the formation of our National Health Service in 1948, which is a service that is free to everybody at the point of delivery. And the National Health Service has become a core aspect of identity for British people. It's one of the things that they value most about being British, and one of the things that they are that is most important in their hierarchy of things that are important politically for them. The National Health Service is very, very close to the top. It also strengthens your sense of why it's a good thing to be British and to feel pride in Britain. So the same kinds of opportunities will be present also, I think, in Ukraine to do things that our citizens see their own interest and value in. Another thing wider society can do is to be responsive to groups with specific needs, such as the families of ex-combatants. So to give some thought to what are the channels of communication for these different groups? How can they reach decision makers in government. What is the mechanism by which people who may be living in a small village or people who don't have any political connections, how can they get their voice heard? How can they alert the authorities to problems that are very real and that are preventing them to recovery? So having new ideas about channels of communication and encouraging people to use them. And also protection from additional harms, such as high levels of self-destructiveness and violence. And we've seen that traumatic experiences are likely to increase the risk of suicidal ideation but also domestic violence. So providing support for families who are worried about these concerns is also very important on the societal level. Now, what can families and communities do? So I think advice to parents about how to talk to children about what they have lost and what they have witnessed, and how to recognize and respond to children's distress is enormously important. And for many of us, this is not something that we necessarily know how to do or have much idea about. Many people may simply not respond to they may know that or suspect that their children are distressed, but not really know what to do about it. So there is plenty of advice available from national child traumatic stress networks in the US and the UK, with a lot of good advice about how to talk to children. So, for example, talking to children in a way that is appropriate for their age and what they can manage. So not telling them things that are going to be distressing and upsetting them further, but allowing them to talk about things that are on their minds and that they're worrying about at a time that they want to. So not putting pressure on children, but adults being responsive to children's wishes to talk about something upsetting that's happened to them at the right time. So there is lots of advice about this, and this is a sort of major way in which we can help children and think about the health of the next generation, who will have had a lot of very difficult experiences that they have gone through. In some cases, parenting programs may be very helpful for families under very high levels of stress, where one or more people in the family suffers from PTSD, for example, or another psychological disorder, and supporting them with parenting programs may be very helpful in giving parents alternative strategies to do when they start feeling very under stress, how they can respond to that, what kinds of things are likely to be helpful for their children, and giving them a source of support to go to when everything is feeling very overwhelming. Thinking about re-establishing social bonds in shattered communities. How can people be put back in contact with others who were very important to them in the past? How can, even if it's on a virtual level, often people may have completely lost contact, they won't know if other people are alive or dead, how to contact them. Re-establishing these social bonds may do a great deal for the mental health of the whole community. And advising local communities on how to begin to rebuild a functioning administration after the conflict, and if wanted, to how to create memories of things that have been lost, will also, I think, be useful. So we can also think about restoring the mental health of individuals. And here I think there is a big role to play now, but also in the future, for national and local leadership and health education campaigns that acknowledge and destigmatize psychological symptoms. And that means things like, for example, national and local leaders mentioning their own psychological symptoms, how they've dealt with them, the treatment they've received for them and whether that treatment hopefully was helpful. So providing those sorts of role models will be very, very helpful. Allowing communities to make decisions about their own mental health treatment rather than imposing external solutions. And one thing we've noticed in other countries is that often enthusiastic but unqualified groups and individuals are very keen to offer help and therapy, even though they may have no experience of trauma and really not know how to do this. So a lot of the intervening effectively is also knowing what to stop happening as well as what to make happen, and preventing poorly qualified people with their own ideas and enthusiasms from doing things that may in the long run be harmful rather than helpful. We can think about also the importance of more training and supervision in evidence-based treatments, which we've talked about this morning. Giving priority to people with severe mental illnesses, such as psychotic disorders, whose care has been disrupted, as well as to those who not just have symptoms, but where those symptoms are unable to, making them unable to function effectively in the family or at work. And again, as I mentioned earlier, thinking about those people who are going to have delayed onsets. How are you going to identify the people who will only develop symptoms later, and how to reach them and let them know that there is kinds of help available? So just a final slide, which basically says there are no easy answers. The collected evidence does not support a specific intervention model nor a set of standardized best practices. Every traumatic situation, every country, every set of communities is different. So it's more about flexibility and adaptability to the specific circumstances. So it's about listening, it's about communicating, it's about being prepared to do things differently if what you're doing to begin with doesn't seem to be working very well. Not imposing solutions that from outside that other people have suggested or may have worked really well somewhere else, but may not be right for your specific situation. And above all, aiming for the resumption of everyday life, reducing inequalities, addressing social injustices, rebuilding local economies, seems to be the most appropriate course of action to improve the overall mental health status of the affected populations. So there's lots to be done, but people can contribute in many different ways. And I think that is the message of the international research. Thank you very much.
Thank you, Chris. We have a number of questions from the audience. If I may, just a sec, I will come to the beginning of the questions. Are there specific protocols in Great Britain for those who suffered through the military action, and would it be possible to use them to make something like that in Ukraine? That was one of the questions from the audience.
Yes, I mean there certainly are protocols, and because the British Army has been involved in so many conflicts over the years, they've spent a lot of time thinking about how to help both people who are actively serving and veterans, and providing services for them. So there is a lot of expertise in the UK military that I'm sure they would be very happy to share with all of you in Ukraine. And I can help, if necessary, to put you in contact with relevant people who could help in that process.
The second question is the following. Do you think that multidisciplinary teams should be used in the management of PTSD?
I don't think there needs to be a rule about that. I think multidisciplinary teams can be helpful for complex cases where people have physical disorders, they have complex psychological disorders that may require a high level of protection from harm, for example, that may require periods of inpatient treatment. So I think for these people with very complex disorders, multidisciplinary teams can be very useful, particularly in dealing with the social aspects of their problems. But I think also there are many people with PTSD for whom people who are suitably qualified in trauma-informed treatments can be treated by individual therapists, and maybe who can then maybe call on others if necessary.
Valeriya, do you have questions for Chris?
Yes.
Please go
ahead. Thank you. We do have questions. Thank you, first of all, for such a deep, thoroughly done expertise and emotional analysis of the state we are discussing today. Maybe it's not very professional, but I must say that I have found some signs of PTSD from myself. So doctors are also maybe can be the group of risk for development of such kind of disorders. But I have a question from the psychiatrist. And from their point of view, the most vulnerable group of risk and not only risk but development of PTSD are the children. And they meet today the states of comorbid states like stable refusing from taking food, menstrual disorders, alopecia, and others. And this is the same question from our psychiatrist, the multidisciplinary management of those states, and maybe from your point of view, some protocols that can organize such kind of help for this group of patients. Thank you.
Yeah, thank you for asking. This is a really important question. I myself am not a specialist in working with children, but we do in the UK and the US have very well organized groups of professionals who specialize in these kinds of questions and in developing appropriate protocols. So again, I can help to put you in contact if necessary with those networks, and I'm sure that they will be able to provide very helpful advice based on our experience and based on international literature, which you can then decide if that is relevant and helpful for you.
Oh, thank you very much. We'll appreciate for such a possibility, and we'll get in touch definitely. Thank you. Most of the questions that I had before, you have answered in your very widely developed lecture. Thank you very much. And that was those questions that were interesting for me. You said that there is no use of discussing that, like a neurobiological underlying of the PTSD. I understand that there is no reason. And promising, maybe not existing, but promising pharmacological treatment or intervention for PTSD that are being developed for now, that do not exist until now, but still are being under development for now.
Well, I think there are one or two treatments that there is emerging evidence that they could be useful. So one, for example, is transcranial magnetic stimulation, very much along the lines that it's been used for people with depression. And as you all know, there's a very strong comorbidity between depression and post-traumatic stress disorder. So this is something where the evidence is sort of promising, but the individual trials have had varying results. It is not yet in a position to be recommended generally, but for some individuals, this may be a very helpful approach. Neurofeedback also has been used. So helping people to strengthen those particular patterns of brain functioning, brain waves that are associated with conditions of calm and reflection. And so making those stronger. There's sort of emerging evidence that this may be a useful technique in the future. But also other interventions of quite a different kind, like yoga or acupuncture, there's sort of some evidence that they may be helpful for some individuals as well. And I think it's useful to always have a sort of range of different approaches so that the person can try something that appeals to them.
Okay, thank you. We shall try to use most of them and advise them to all the patients and to ourselves also.
Yeah.
Thank you.
Thank you very much, Chris. Thank you very much, Valeriya. Since we don't have any more questions from the audience, I guess we will be closing this meeting, which lasted a little bit more than 1 hour. And again, Chris, thank you very much for such a detailed presentation. The whole thing will be available both with translation and without translation in English version for various audience according to their preferences.
Thank you for inviting me.